Hi, I'm BJ Miller, palliative care doc, here today to answer a few questions that were left over from a talk I did recently. So take it away, Sonia.
Thank you, BJ. All right, first question is how do you help family members who disagree on goals of care for their loved one?
Okay, great question. How do you handle situations where the family are not agreeing on the goals of care, right? Okay. Well, so as ever, my answers are going to be sort of generic. Uh, Oftentimes the details of the family dynamics and the details of an advance directive, who the healthcare proxy is, et cetera. So a lot of details might change some of the nature of the answer here. But in general, um, so as always, the patient, the person who's actually dealing with death or illness themselves, most directly, in general, we defer to them. It's their life, their body, etc. Now, many of us, the way we're wired, we don't make those decisions in vacuums. We want our family and friends involved, especially if if their duties include caregiving, because they have to live with and work through and work with whatever I as a patient decide. So it's really important to get the whole family bought into goals of care. Um, Real quick tangent there. Goals of care is a phrase that may mean something to some of you guys and may be new to others. Goals of care is a phrase that we use in healthcare increasingly. It's not a universal phrase, but especially in the palliative care circles, we use this phrase of goals of care to kind of delineate, articulate what's most important to the patient and the family, so that we can align those goals of care with whatever treatment we clinicians are recommending. So that's what this goals of care is all about. Um, and they're personal. There's not a generic goals of care. Each of us gets to say for ourselves. So, okay, that's all backdrop. So when there's disagreement in the family around goals of care, well, the first thing to check on is everyone working from the same information? There's so many opportunities for miscommunication in clinical encounters and around these big subjects. I mean, miscommunication is the norm under normal circumstances, let alone these sort of hypercharged circumstances. So first thing to just check is make sure everyone in the group or in the family is dealing with the same information and has the same sense of context, etc. So oftentimes that's all you need to do, and that can clarify differences of opinion. If that doesn't quite do the trick, then of course the question is, does the patient themselves have a very strong opinion about what should happen? And some family members are in disagreement with the patient. In the American bioethical sort of framework, the patient's opinion would trump. So sometimes a patient may not be thinking clearly from medications or from illness, and so we're not really able to act on what they're telling us. They may be delirious or unconscious, etc. So then we look at the advance directive. Do they have an advance directive? What clues are in the advance directive about how to treat this particular decision? And if there is no advance directive, or the advance directive leaves you scratching your head, and then it would really technically fall to the proxy. Has an official durable power of attorney for healthcare been named, the healthcare proxy. That's the person who's deputized to make decisions on behalf of the patient. So if the patient's not really able to participate in this goals of care conversation, and there's loggerheads, then the trumping vote would be the healthcare proxy. So that's sort of the pecking order. But I would say don't let up on communication, and I would get all the play. So that's sort of, like I said, the general pathway. But I wouldn't invoke the sort of I wouldn't invoke the power of a proxy, for example, at the expense of other family members. Make every effort to talk it out, and ideally getting all the parties in the same room at the same time to hear the same information, and so people have a chance to talk through and to each other and talk things out. And ideally, that would include whoever the clinician is who's most involved, whether it's an oncologist, a primary care doc, or a nurse representing the palliative care team, or whoever it may be. But it would be great if a clinician who's actually affecting these decisions is in that mix too, because sometimes families will have an idea what should happen, or a patient does, and we've come to realize that that opinion is completely unchecked by the realities of what's possible in a medical setting. So try to involve the clinician too in this sort of singular conversation. And it may need to take several conversations. It's not just the logistics to wade through here. There's a lot of emotion in this mix. So give it all the time and space that you can. So anyway, that's a long answer to a very important question. I hope that speaks to your particular needs, but that's a general framework.
Okay, great. Next question. What do you think of the Hopkins study that showed that psilocybin produces substantial and sustained decreases in depression and anxiety in patients with life-threatening cancer? Is this something you might incorporate into your practice?
So yes, the research coming out now, so some of you probably know, many of you may not, but psychedelics as a cluster of chemicals has a long history besides just the American 1960s. In fact, psilocybin, LSD, other traditional medicines, plant-based medicines go back thousands of years in tribal cultures. So there's a long, long history around psychedelic therapeutic use of mind-altering psychedelic substances. So that's one point. Know that. And included in that history is in the 1950s and early 60s, before the sort of hippie movement took over and changed a lot of this, the sort of context of these drugs. There was amazing research being done that showed amazing efficacy for the psychedelics around addiction, around anxiety, depression, death anxiety, etc. So now there's been a resurgence in the last couple of years, and big time institutions, NYU, Johns Hopkins, UCSF, others are, the research is blossoming. And so far, the data really are pretty profound, that even after one session with psilocybin, that's probably the most studied right now, in one guided session with therapists, it's not just take mushrooms and go out in the woods. In these guided sessions, people who are seriously, seriously bogged down by death anxiety, one session can really unlock a lot of the sort of wadded up feeling inside of people. The data are profound. People report feeling no or very little anxiety around death, report feeling connected to the cosmos in a new, palpable way, and who just have a sense that they can tap into, that they're not alone, that they're connected to the universe. These are profound reactions. We do not, in the medical world, we have no other chemicals that achieve anything like this. So this is big, big stuff, and the data so far are amazing. Very few or very little downside when used responsibly in this therapeutic way. So yes, and to answer your question, I am very bullish about this research. Of course, we need to stay naked to the data and let's see, let's not be cavalier. But I am very encouraged for existential anxieties, et cetera, that psilocybin and other psychedelics have a real role to play in society and the medical world. I think we'll be hearing a lot more of this in the coming years. And absolutely, I counsel folks around this issue through Mettle Health. We do not participate, and we're not a clinical organization. We don't participate in those sessions, but I certainly counsel people around the power of these medicines. And as Mettle Health grows, it would be a very exciting frontier and very much up our alley as an organization to lean into this work. We're not there yet directly, but someday hope to be.
All right, great. Next question is, any suggestions on how to offer your incredibly practical resources like Mettle Health or your book to a dear friend with stage 4 lung cancer?
Yeah, we get this a lot, don't we, Sonia? You and I and Shoshana, versus vis-a-vis our book, A Beginner's Guide to the End. We heard from so many people that they liked the book and found it very useful and knew several people, whatever, who could really benefit from this, but they were afraid to actually give the person this book for fear what it might symbolize. If you give someone a book called A Beginner's Guide to the End, are you saying, hey, I think you're dying soon, or I hope you're dying soon? So people have really struggled to how to give this information to people who might benefit. And it just goes to show how charged we are in this society around death and dying, that we can't even utter the words. So I don't mean to shame anyone who might have that response. It's more like it's an indictment of how we as a society and how we as a sort of a culture in the US, not that we're a culture, but the sort of the amalgam of of culture in the US has found death so repugnant that we can't even talk about it. We can't even open that conversation up with each other. So, you know, we got a ways to go. I think a lot of reasons why we do these webinars and public sessions is to begin to chip away at that taboo so that we don't have to be shy about talking about our nature, about our reality, about our life, about our death. So all that is to say, I thank you for your question. I really hear you. So some ideas, you know, the book is one thing because death is in the title. But sometimes people will say, you know, give people that book and put dog ear a chapter on symptom management or on coping in general and say, you know, I really found this chapter very useful. You might like it. And some of that may be a Trojan horse way to get that book into someone's hands around a specific topic. And then they have it and can reflect on it. It's a great thing to do to give that book to caregivers. It's less charged. And over time, if caregivers are referring to a book like that, well, then it starts seeping into the conversation, and then you might have an easier time. So giving to a family member, etc. Or owning it yourself, like, hey, friend, I read this book, and I have to tell you, as someone who's not even sick, I found it very useful, or whatever else. And you can kind of own the experience and say, I hope you find it useful. I don't mean to send you a harsh signal. I just think there's some things in here that could be helpful. So those are some ideas, all on the book side. Mental health, to my mind anyway, mental health is not just, it's not, you know, death and dying is a piece of what we talk about, but it's just a piece. So I think referring someone to mental health is much less charged. But we've noticed that people don't do as well. If someone told them to come have a session in mental health, it's not the same as if they kind of want, you know, obviously if they are reaching out, they want to make it happen. So you might just simply let them know about mental health existence and just say it may be helpful. You don't have to, you don't have to be suffering in a big way. You don't have to be a certain level of sickness to benefit, etc. And you can say, you know, I've had a session as a caregiver, or as a family member, or as a friend, and I found it very useful, etc. So mental health seems a little less charged, so I would just point them to the website and leave it at that. Like I said, I wouldn't push people too hard. Even if they could benefit from this kind of care, they really need to choose it eventually. And so just making folks aware, putting it in the soup and leaving it at that. And eventually people might come around to choosing it themselves. Last thing to say there, we do have these little freebie 20-minute sessions. So there's nothing lost. So I could just point to, hey, just give these guys a try. Sign up for a 20-minute session. Doesn't cost anything. You can hear what they can do and what they can't do. And, you know, that's a little way to kind of diffuse the charge there. So anyway, thank you for your important question. We run into this a lot and we struggle too. So if you have ideas, shoot back, please.
All right, next question is, has it been your experience that most people in palliative care want to talk about their thoughts and feelings about death? I'm assuming this means people who are receiving palliative care. Have you found there are essentially universal ways to assist, support, and console someone in this transition or someone who is grieving a significant loss?
So can you read the question one more time, Sonia? Sorry.
Oh, of course I can. Of course I can. Has it been your experience that most people in palliative care want to talk about their thoughts or feelings about death? So that's the first part of the question. And then the second part is, have you found there are essentially universal ways to assist, support, or console someone in this transition or someone who is grieving a significant loss? So I think this is specifically for the end of life.
So first question, so in palliative care, so patients, families, you know, folks who are one way and another involved in palliative care, receiving palliative care. It's interesting in my own experience, and I don't have data to quote here, but in my own experience, you know, it's infrequent when someone says, hey, doc, I would like to talk to you about death. That happens, and I love when it does, but more often than not, people don't front with that, and they don't generally kind of quickly go there. More and more they do. More and more, I think this is part of our conversation in public now. But what's much more common with palliative care patients, clients, et cetera, is they'll come to a palliative care program seeking help with pain management or nausea or some symptom issue or making some medical decision or maybe talking through an advanced directive. But very often the way in, the thing that brought them to palliative care is not where the conversation stays. So it may be that someone comes to me and wants to talk about, communication problems or how to get what they need from their doctor or to talk through some of their symptoms. And that is a place to start. We build a little trust, have some time together and get to know each other, and maybe second, third, fourth visit, whatever, maybe then with all that trust established, then we might get into sort of questions around medical decision making, which invariably begs sort of contextualization, and contextualization sort of begs prognostication. And in this way, we can kind of tiptoe into the subject that way. There is no pat answer per se. It depends on what's going on with the person, where they are, what their interests are, what they can handle in that moment, intellectually or emotionally. This is big stuff. So those are some kind of pathways of how this kind of can play out. In general, though, I think for a good counsel is, some folks, depending on the dynamic, the relationship, you might just simply say, hey, just acknowledge, like you can own it, like I'm aware of all the loss in the air, or I'm grieving too, or whatever it is, you can kind of own the emotion yourself. And sometimes that way you can probably open a conversation around the loss specifically or death specifically. Just sending signals to this crew that you're open, that you're willing to go there, that you're having your own thoughts and feelings too, that you'd like to share. These are ways to kind of make it the conversation a little bit more accessible for folks. And in so many ways, you offer the space, you offer the thinking and feeling, but that's about as far as you can go, really. People have to take this up for themselves. And, if with good intentions, sometimes people push harder and harder to try to get someone to open up, and then heels get dug in, and then you get defensive. And then, no matter what you say, they're just going to sort of not go there with you because you push too hard. That happens not infrequently. So again, make the space, the safety, offer up that kind of kindness and again safety, but you can't force them to talk about things that they're not going to talk about. And often that people will get there through this route, and sometimes they won't. One last thought on this. Very often, if you're trying to talk to someone about death, their death or somebody else's, oftentimes a way in is just talk about life. Like, what do you care about? What do you love? Like, what's going on for you? And that can tip into like, what are you worried about? What are you worried about leaving or losing? And that can be a way to sort of back end into the conversation around death by talking about life. And it's not a sort of trickery. That is, life and death are very much entwined. So, okay, that is my whirlwind answer to that question for now.
Thanks, BJ. All right, next question. It's got a little bit of a setup. My mom is 89 and openly expresses being ready to die due to feeling no sense of purpose. I am a bit more at ease talking with her about this, but still want to delve deeper. So question one is suggestions on how to talk about this so I can better understand how to connect with her. And number two, are there any ideas on self-care and caregiving balance? She's in independent living now, and I am her sole caregiver, and I feel a bit forgotten at times by family, except by my mom, who totally appreciates me.
Okay, can you circle back to the beginning of the question? There's a lot there. I just want to make right.
Yeah, so it sounds like mom is expressing a wish to, or feeling that she's ready to die because she doesn't feel like she has a sense of purpose any longer. And so she's hoping to speak with her mom and just hoping for a suggestion on how to talk about that with her.
Okay, great. That's great. So a couple thoughts. A lot of us want to talk about death, but we just don't know how to, whether it's safe to. So it's just an awkward conversation. So I wouldn't let awkwardness get in the way. That's just the way this kind of plays out, especially to kind of get the wheels turning, So one thing to do is to consider, like, there's a thing called dignity therapy. A man named Harvey Chochinoff, a psychiatrist and palliative care doc in Canada, sort of outlined this idea called dignity therapy. And essentially what dignity therapy is a life review. So if mom is feeling a lack of purpose, feeling like she wants to get off the planet, etc., a way in is to simply sit with mom and say, hey, mom, just basically go back in time. Mom, tell me about your childhood, uh, your first love, your first kiss, memories of me, just open up the memory box and just get people thinking and feeling about their life to date. That can be itself so powerful. You will learn cool things about your mom, but she'll feel heard and seen and that someone wants to know about her life. And then very often people kind of by articulating their past are reminded that, hey, I've been around a while, I've done some things, I've had a life. So it can confer this dignity in one way and another. It can be a beautiful process. So that would be a way in. And then once with all that in the mix, with all that backdrop there, then you can kind of lead into now, like now here we are, and so much of that stuff may be out of reach now, but what is in reach, mom? What might you want to get to before the end? Even if it's a small little thing. And sometimes I often land on, you know, tell me some toeholds of joy you have in your day at all. It can be the smallest thing. Maybe it's a view of a sunset, or watching the birds on the bird feeder, or a certain meal, or going to sleep, or whatever it is. Even folks who are scarred down and miserable can often find a sliver of something that isn't all bad. And so that can also be a way to name some of these toeholds, and you can begin to structure your day around them. And I love this aesthetic piece because it doesn't require meaning. So yes, part of the goal here is to think about where you might find new purpose and new meaning in life now in this new context. And I also like to leave some room for meaninglessness. Sometimes meaning's out of reach, but that doesn't mean life doesn't have its own value. And sometimes that its own value are things for their own sake, art for art's sake, food for its own sake, just for the flavor, whatever it is. That's why I love the aesthetic domain. It doesn't need to have a narrative. It doesn't need to have any meaning. It can be a way to kind of swallow in meaninglessness, but feel something, feel alive. So that's how I might approach someone who has lost a sense of purpose, but who's still here for some time, who may even be able to find some new purpose, or at least get into just letting go of the need for purpose. So that's one part of the question. Sonia, can you remind me the rest of the
Yeah, of
question?
course. So the rest of the question is, any ideas on self-care and caregiving balance? Sounds like mom is in this independent living, and I'm her sole caregiver, and I feel a bit forgotten at times by my family, except my mom, who totally appreciates me. So maybe more of an appreciation question about how to convey the work that she's doing to her family.
So, not knowing the details of the dynamics in your family, but first just to acknowledge, caregiving can be super hard in all sorts of ways, including in a way it just can feel so underappreciated, unseen, unwitnessed, just like patients often do. But in some ways, caregivers have it harder insofar as, most of us give some credit to the patient, the person in the bed, and healthcare has structures and systems to tend to patient care, but we don't have much in the way of caregiving. That's why we've been doing a lot of these caregiver webinars through Mettle Health and the Center for Dying and Living, is to just begin to offer some space for this very important work that can get so easily unseen and forgotten and underappreciated. So I'm just stating the bigger problem. It ain't just you, my friend. They're commenting on some big forces that play out in all sorts of ways. So one thought is to really focus, if mom is a source of appreciation, obviously that's really, that dynamic between the two of you is most key. And maybe it is families witnessing that, maybe if they're around and hearing mom share her appreciation for what you're doing, and maybe they can kind of pick up on that indirectly. Maybe if it's so bad, if it's really getting to the point where the family's at odds and stuff, if mom's able and willing, if it feels right for mom to talk to the rest of the family, or call a family meeting and say, hey, so-and-so is providing a lot of care and it's super helpful, but I'm worried about her. She might burn out. Can we talk about how more of a team sport for this caregiving stuff, or whatever else? In other words, letting your mom be the boss and teach the rest of the family about what's actually happening here. And in this way, maybe share the load. And by virtue of sharing the load, once rest of your family are doing some of this work themselves, they'll probably say, oh, geez, wow, I didn't realize how much work this was, and now I really appreciate you. Maybe. And then the last note would be simply whatever the rest of your family are going to do, everyone's swimming in their own stew. They got their own guilt for not being there more. So that's a big source sometimes. If you're the one who's doing a lot of work, they may not be able to look at that because they're ashamed that they're not doing more. So, learning how to read people, it's lonely as hell. And the last thing, I would encourage you to think about that in case there's some forgiveness on your part, so you don't have to walk around with resentments. But it's just tricky. And so that points me to this last little bullet here, which is trying to find a way to be your own judge and jury in this work. And if you're not getting grief from others, and that's important. I'm not going to talk you out of that, but to sort of shore up the floor for yourself, you being your own judge and jury every day, checking in with how you're feeling, saying, okay, hey, I did this and that today, I felt this and that today, I'm showing up, at least I'm showing up for mom, I'm doing what I can for mom, and I feel good about it. I am proud of myself. Showing yourself that sort of respect and pride and love is absolutely invaluable. In fact, if you don't do that, no matter what your family says to you, it won't land if you're not aware of what you're doing and not able to give yourself that kind of love. It's very hard. A lot of us in healthcare struggle with that. So, but this is where it can be so developmentally powerful. So be your own judge and jury underneath all this. It was my last little bit of advice for now.
All right. Next up is, I recognize death may be near and want to see death as a friend. What concrete actions can I take to make that friendship bloom?
Well, beautiful. Yeah, I mean, thank you. The question implies it, which is so important. We all get to have our own relationship. Just death is, yes, it happens to all of us, but how it happens, our own feelings, our own thoughts about it, what we think it represents, what the heck we think death is in the first place, it's all very, very subjective, and each of us gets to say for ourselves, and this can be a real fascinating exploration. So one thing to point you to would be like reading the existentialists. Ernest Becker's book, The Denial of Death from the 70s is very powerful and a good cultural critique. So in this way, you can begin to kind of immerse yourself in the subject a little bit. There is a whole field of study called thanatology, which is the study of death. So if you want to kind of apply your intellect there, you can just read all about it and study it. The tear management theory guys, I can't remember their names right now. The tear management is a current sort of framework for understanding death anxieties, and that's fascinating stuff. So I would point you to tear management theory. So those are all sort of heady things. But aside and apart from that, I would also encourage you to just pay attention to your daily life as you walk around. When you see dead, roadkill, when you see bugs on your windshield, when you see leaves falling from a tree, begin to see, just look for all the signs of death and decay that are in front of you all the time. And some of those things may actually even be stunningly beautiful. And if we can, so this is a way to pry open a relationship to death. You start seeing it more fully, more with all its power and all its charms and all its necessities and all its pains. It is, begin to kind of notice it everywhere. And this way you'll see how it's integrated with life, and that'll drop your own fear and open up a pathway of sort of, if not loving death, like the Rilke poem, loving life so much that it includes that your love extends to death too. So those are some ways to kind of begin to sink in, to settle into the subject, make it your own. There are also death meditations you can look up, ways to sort of bring into a meditation practice of imagining your own death, settling into your own death. There's corpse pose in yoga. So there are all sorts of ways to begin to open up this relationship. And then I would just play with it yourself. What works for you? What makes you feel closer to it? Sonia and I posted a video that may be very interesting. It's an animation that shows death as this loving, beautiful creature, this thing that has to, unfortunately, everything it touches dies, and how sad that must be for death. Anyway, we'll try to remember that link, to include that link. But that just shows you how differently, how much freedom we have with which to view this thing called death. So that's my answer for now.
All right, this last one has a bit of a story before the bit of a lead up before the question. So I'll read that and then we can go into the questions. So this person states, my mother-in-law survived a large hemorrhage stroke in mid-February, which left her with left side paralysis. She does not currently qualify for hospice, yet says she can't go on living like this and wants to die. She is frequently tearful and despondent at times, though she continues to eat and participate in some of the rehabilitation exercises. We all want to honor what she wants. However, I think she is ambivalent about wanting to die and is scared and sad to leave precious family members and grandchildren behind. She does not have a strong spiritual practice or tradition, but says that she has been lately praying to God that she will die. So there are two questions that she asks. First question, are there ways that I and we as a family can support her in her suffering to help her tolerate and make meaning of her current situation and to find a way to decide and come to peace with when and how her body, mind, brain will die? And then second question, and we can come back to these, is there an appropriate moment to advocate with medical staff for hospice? When is that point, and what are some good options to gain more information about hospice?
Okay, great. So the first one, sort of about how family members can support this person as she waits life and death post-stroke.
Yep.
So one thing, there are a couple different avenues to consider. One is just from a sort of a physiological and medical angle. We know that depression is very common after strokes. So one, and depression will color everything that she's thinking and feeling. So one thing to be right out of the chutes would be to talk with her clinician, her medical team, about screening her for depression. And if she is depressed per se, not just sad, but I mean a chemical physiologic depression, then antidepressants may be very helpful. And those can take a little while to work, but can be very helpful. So I would first rule out depression. I would also, on that note, sort of, is there pain that's not being treated? You know, are there symptoms that aren't being really addressed very well? Because you can imagine that our will to live is absolutely is curtailed when we're physically miserable. So checking in on all the symptom front and how she's physically feeling, etc., checking in for mental health screening, those would be really, really important. By treating those issues, you might find a different affect and attitude on the far side. So that'd be one point. Second point is to just basically show her, continue to love the heck out of her. You know, it may be a cry for help. She may be just processing her own thoughts and feelings about this thing called death. So she sounds like she's involved in her own sort of process of making peace with this idea. And sometimes it sounds like it leads her to actually wanting to die because life has become intolerable, etc. But as someone, that's a personal journey, and as someone wades through, is the best thing you can do as a loved one is just love them. Sometimes family are so freaked out by conversations around death or et cetera that they'll shut the conversation down. So doing what you can as a family to make it safe for mom to share these thoughts and feelings. And I wouldn't even try to talk her out of it anytime at the beginning. Just hear her and love her. And you can say, Mom, you know, I want you to be around forever. You know, we know that's not going to happen, but I'm here for you. And, you know, please keep talking to me. We can go through this together in a lot of ways. And we also, when death is near, we can plan for that too. It may not have to be so hard. So in other words, just showing her that you're not going to run away, even when she's talking about hard things like death. Being there, showing up emotionally and to the degree possible physically for her and loving her no matter what's coming out of her is really, really key. So those are some ways to support her. And then the last little note there would be trying to talk about death specifically, follow her lead. So in those moments where she says, I've had enough of this, I want out, or something like that, that's her cracking open the window and saying, well, Mama, you know, or, you know, I hear you. And can we talk about that? You know, are you afraid of anything? Are you worried about anything? Does death sound appealing to you now because life is so miserable, or do you find yourself more and more curious about death? Or, you know, just opening it up. When she, and again, it will always be clunky. Talking about death is always clunky, so don't let that scare you. But when she makes those statements, treat those as a little crack of the window to walk on through, to go through that window. Go through. When she cracks open the door, go through the door. Versus if she's not talking about those things and you say, come in and say, hey mom, I want to talk to you about death, or that can be a little too much and people might get defensive. But when she makes those little comments, I would sit with her, pry it open, hold her hand, support the heck out of her, but dare to talk about it. What are her worries? What are her fears? You know, etc. So those are ways into this big conversation, ways to be supportive for her as family members. You can feel very powerless, and there's may not be, after all, so much to be done with meds or anything else, but just loving her, just being with her, just witnessing her. Sometimes that is the magic all by itself. All right, what was the second question?
And then the second one is there an appropriate moment to advocate with medical staff for hospice care? When is that point, and what are some good options to gain more information about hospice?
So yeah, such a good question. So doctors in particular, are famous for referring to hospice late. And they're the ones that are uncomfortable talking about death. They're the ones who keep sidestepping the subject. And so it is very common that doctors and other clinicians don't think about hospice until it's way late in the game. And so I'd really encourage you as a family, just like you're doing, this is sort of the advocacy role, you going to them and saying, hey, if we're not ready for hospice yet, like when would we be ready for hospice? If now is not the time, ask them, when would be the time? You know, make it clear that it's on them. If they're not talking about it, that's on them. You're willing, you're able as a family to go there and push them. Okay, I hear you're saying this is not the time now, but when would be the time? Make them answer that question. So that's one avenue of sort of activism, kind of pushing the clinicians and making clear that that's the kind of care that you would look forward to whenever it's right. And again, the norm is late referrals to hospice. So it's never too soon to be thinking about hospice. The other thing to consider doing with perhaps the clinical team at the Independent Living Center is call a local hospice and ask for an informational interview, and just welcome hospice into the mix as a non-threatening conversation. They'll usually have a meeting with you and talk out what they can and can't do, when they may be relevant to your care, etc. So we might just go around the Independent Living Center staff and invite hospice into the mix to do an informational interview. And then you go back to clinical team and say, hey, we had an informational interview with hospice and they said this or that, you know, what do you guys think? That could also prompt the conversation to go a little bit farther. So in general, it's never too soon to at least consider hospice, never soon to have an informational interview. And even if you got on hospice too soon and you started getting better, or you didn't die soon enough, well, people can re-up on hospice. People can quit hospice, can, with the stroke of a pen, sign off a hospice and return to it later. So always encourage people, the second they're thinking about it, or even before they're thinking about it, to consider it and explore that option. So I think, Sonia, are we missing a note on that one?
Nope, that sounds right to me.
Yeah, okay, great. Well, let's leave it at that.
Okay, thanks, BJ.
Thank you. Okay, girl.